You have diarrhea, I'm in great shape. All diarrhea should first be thought of as being acute. Oh, that's a cute little diarrhea you have. No, not cute diarrhea, acute. All diarrhea first should be thought of as being acute diarrhea, and we should always exclude infection first. We should always exclude infection. How do you know what the diarrhea is going to turn out to be? It might be infectious. So first thing to do is to exclude the infectious diarrhea first. In other words, it might turn out to be lactose intolerance, but not until you exclude viral diarrhea. Hey, it might turn out to be inflammatory bowel disease. Oh, not until you exclude the Salmonella, Shigella, Yersinia, E. coli. Not until you have excluded the infection. First exclude the infection. Then you can go on to the other things. Though the short answer for excluding infection is that the first thing that's useful is stool for white cells. So stool for white cells and red cells. Now white cells and red cells, if you have them, white cells and red cells basically mean the same groups of diseases. White cells and red cells are most commonly associated with invasive diarrheas, Salmonella. That's kind of a nice name, isn't it? Hey, what's your last name? Hey, Salmonella. It's like a nice Italian last name. What's your name? Salmonella. Okay, Yersinia. Yersinia. Salmonella, Shigella, Yersinia. All of these. What's the most common? Campylobacter. Campylobacter and Salmonella are the two most common causes of infectious diarrhea and food poisoning. Now, you cannot distinguish these two by clinical symptoms. You cannot distinguish between any of these, between this, between E. coli, between Salmonella, Shigella, Yersinia, between Campylobacter, between Vibrio, not cholera, because we don't care so much about Vibrio cholera, because it doesn't happen here. Maybe killing a couple million people the rest of the world, but USMLE? Well, not us. We're worried about Vibrio parahemolyticus, but not Vibrio cholera. We're worried about Vibrio parahemolyticus because the most common association with Vibrio parahemolyticus is shellfish. Shellfish? No, shellfish. Mussels, oysters, clams, shellfish, filter feeders. This is what they are in there. They go like this. Did you know that a mussel and an oyster and a clam have to filter nearly 50 gallons of water a day in order to feed themselves? Did you know that those organisms, those filter feeders, have to filter 50 gallons a day? And what are they doing as they're filtering those 50 gallons a day, those filter feeders? Why, they are concentrating all the microorganisms. Why, you could think of a mollusk and a clam and an oyster that every time it breathes in and filters out, it's collecting all the microorganisms that go through it. Why, you could think of a shellfish as a stool concentrating device. Tasty. Get the horseradish. Now you know why you have it with a shot of vodka. It's to sterilize all of the microorganisms that are in the shellfish. I'll tell you, I haven't gone to a raw bar in years unless I take ciprofloxacin in advance because the drinks are so contaminated it's filled with microorganisms and you don't taste them. Shellfish, Vibrio parahemolyticus. What's the association most commonly with E. coli? E. coli 015787 and hemolytic uremic syndrome. Interestingly enough, this fact about the association of hemolytic uremic syndrome and E. coli 015787 has been so published, so talked about, so discussed that we forget that E. coli 015787, why don't they give this thing a name? I don't know. Well, why don't you name it? Why don't you name it like E. coli Susan, E. coli Fatima. I'm tired of saying E. coli 015787, but that's the name. It has been so talked about with this association with hemolytic uremic syndrome that actually that's not one of the most common wrong answers. The two questions that are interesting about this are, number one, don't answer to give antibiotics. Giving antibiotics can potentially make it worse. As the organisms are dying, they theoretically release more Shiga-like toxin, which can worsen the HUS. Point number two is even though the platelet count may go low, 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 low with the hemolytic uremic syndrome, don't give platelets. No, please, please, I want to give platelets. No, no platelets. But the platelet count is so low. Don't give platelets. It can make the clot worse. Oh, please, I want to give platelets. No platelets and no antibiotics. All you've had to know so far is the association. E. coli 015787 and hemolytic uremic syndrome. That's all you have to know. Now, yes, I know. Salmonella with chickens, salmonella with eggs, salmonella with chickens, salmonella with eggs. I know. Salmonella with chickens and eggs. But the question I have for you is, which comes first? The chicken or the egg? What would your mother say? The chicken. Mom would say, the chicken, honey, you better believe it. The chicken comes first. And it happens to be that the ovaries within the chicken are infected with the salmonella. When the organism is passed into the egg, it is passed You getting this? I'm trying to point to my ovaries here. Okay? It's passed transovarially between the chicken's ovaries and the eggs. So that's why you have to go out and choke all the chickens. Because basically, if you just wash off the eggs, it doesn't work. That's why you have to get rid of the flocks. It's the chicken ovaries. Wow, infected chicken ovaries. Tasty. Now, chickens and eggs, and it's the ovaries in the chicken. Now, if you go down to the local supermarket, which I will avoid mentioning by name for liability issues, but if you go down to the local supermarket and you're the kind of person that you have such a dull social life that, God, the only action you're getting is in the poultry section. And so you go down with a swab and some agar and you say, let me culture all the chickens. You can actually culture microorganisms from a minimum of 16%, 1 out of 6 chickens, and as many as 60% of the birds. The raw chickens are infected or contaminated, colonized with these organisms, one of them, somewhere between 1 out of every 2 and 1 out of every 6 chickens. From 16 to 50 or 60% are actually covered with bacteria in the store. That's a real high-class store. Underneath the plastic wrap is these bugs. So if you're worried about biological weapons, check the poultry section. They're there. Anytime you want, you can find drug-resistant E. coli, okay, and drug-resistant salmonella. It's there all the time. So that's both salmonella and campylobacter. E. coli 015787 with hemolytic uremic syndrome. Don't give platelets, don't give antibiotics. Vibrio parahemolyticus with shellfish. Now, these organisms all give red cells. These organisms all give white cells. The only way to tell for sure the exact etiology is you have to culture them. The only way to tell for sure the exact etiology is with a bacterial culture. The only way to tell an exact etiology is with the culture. You can't tell for sure. The thing about chickens and eggs is suggestive. Now, the things that don't give white cells or bacteria, white cells or red cells, pardon me, white cells and red cells, viruses do not give white cells or red cells. They're not invasive. Giardia does not give white cells or red cells. Cryptosporidium does not give white cells or red cells. Cryptosporidia, Isospora or Isospora, depending on where you like to put the emphasis, does not give white cells or red cells. And the preformed toxins, such as Clostridium perfringens, preformed toxins, does not give white cells or red cells. Look for the turkey that your mother left out last night and you stumbled in at 4 o'clock in the morning and eat the turkey that your mother made at 3 o'clock yesterday afternoon. The turkey that's been out on the counter for 12 hours. God, what's that special something Mom puts on the turkey? Clostridium perfringens. Preformed toxin, but no red cells, no white cells. The other preformed toxins, such as Staph aureus and my favorite and yours, Bacillus cereus, and I like Bacillus cereus because when I ask people the diagnosis, they always yell out at me, be serious. I am being serious. Bacillus cereus. So Bacillus cereus and Staph aureus preformed toxins don't give blood. No blood? Nein Blut? Nie Krov. So therefore, you are going to have just diarrhea and you can't distinguish them until after you've done specific tests. So who gets giardiasis? People with unfiltered water. Unfiltered water, the guy who's out fishing in the stream. You're out there in Wyoming. You're out there, Dick Cheney and you. Hey Dick, what do you got? Nothing. Okay, you're out there fishing. Okay. The post-retirement Dick Cheney, giardiasis, unfiltered mountain streams, gay men, campers, gay men on a camping trip, the happy camper. Okay. Cryptosporidiosis is going to be an HIV with less than 100 T cells. Same thing for Isospora. These things are both HIV-related bugs. Giardiasis. I would have said stool, ova, and parasite examination, except now we're going to stay stool Giardia antigen. So if on the GI tape I say stool antigen, but in the infectious disease tape it says ova and parasite exam, and that's because you could tell from the number of hairs in my head that tape was made a little while ago, not too long ago, but it said ova and parasite exam. It used to be stool for Giardia antigen is more accurate. 90% will be detected with stool for Giardia antigen, whereas ova and parasite exams, even 3 of them, pick up only 80% of giardiasis. Only 80%, even after 3. So 1 gives a better sensitivity than 3 of those. Cryptosporidia is actually diagnosed with a modified acid-fast stain. Acid-fast? You mean like tuberculosis? AFB, acid-fast? Yes, but AFB stands for acid-fast bacilli. This is not a bacillus. It's a protozoan. Okay? It is a parasite. So it's a modified acid-fast stain. Giardiasis was treated with metronidazole, and it is treated with metronidazole. You will answer paromomycin for cryptosporidiosis, paromomycin, and you go, paromomycin? First of all, I don't like anything that stands like paromo. Oh, this is too many vowels. Chief paromomycin. Well, I never heard of this drug for anything else. Well, there's a very good reason you haven't heard of it for anything else. It's because it's not used for anything else. It's a non-absorbed aminoglycoside. It's a non-absorbed aminoglycoside. And as such, it is not useful for many things. And it only helps half the people who have cryptosporidiosis. Isospora or Isospora, depending on where you put the emphasis, is treated with Bactrim. Bactrim is in trimethoprim sulfa. These things don't get any therapy because they resolve spontaneously on their own. They don't get any therapy because they resolve spontaneously on their own. So they don't need any form of therapy. Now, most people who have infectious diarrhea do not need therapy either. However, if the disease is severe, then you need to give the antibiotics. Let's try that again. If the disease is severe, then you need to give the antibiotics. What do we mean by severe? Pain, fever, blood. Pain, fever, blood. Pain, fever, blood, and tender. Pain, fever, hot, 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 hot. Blood, abdominal tenderness. Pain, fever, blood, and tenderness. Antibiotics. Which of the following is the most appropriate antibiotic therapy for this patient? A is ciprofloxacin. Fluoroquinolones. Well, you might say Campylobacter is better treated with erythromycin. Yes, that's true. You might say Salmonella is good with Bactrim. Yes. Well, you might say a lot of things, but until you have the results of the culture, how do you know which one is there? You're shooting blind. How do you know which one is there? Go on now. How do you know it's there? At the time you were answering treatment. Well, you get the results of the culture. No, the culture's 3 days from now. How do you know today whether they need it? You don't. Ciprofloxacin. But, oh, Conrad, you just told us not to give antibiotics for the hemolytic uremic syndrome. What are you saying now, huh? What you saying now, chiquitito? Changing your mind? We caught you being wrong, chico? And the answer is no. If there's hemolytic uremic syndrome, then don't give antibiotics. If there's serious infectious diarrhea, then give ciprofloxacin until you have the results of culture. Serious means fever, blood, and pain, tender. Fever, blood, and pain, and tender. Hypotensive, tachycardic. That's how you know what severe is. Isospora, trimethoprim sulfamethoxazole, also known as Bactrim receptora. Paromomycin for cryptosporidiosis, works in about a third. Giardiasis, metronidazole or tenedazole. Metronidazole is the main thing, stool for Giardia antigen. Then the last one I'm going to give you here is Vibrio vulnificus. Oh no, don't give me another one. I can't stand any more of these. Oh, I couldn't stand another one. Don't give me any more. One more. Oh no, just one little more bug. Oh, I couldn't stand another one. Give me a bucket, I'm going to vomit. Oh no, one more little thin infectious diarrhea. You can do it, Vibrio vulnificus. Okay. What's this one associated with? This one's associated with liver disease because it's associated with increased iron overload states. Hemochromatosis and liver disease. Okay, I got it. Vibrio vulnificus with liver disease, iron overload, okay. Oh, it's in there. Boom! Too much information running through my brain. Too much information driving me insane. You can take it just one little more. It's a stretch. Vibrio vulnificus, liver disease, iron overload, hemochromatosis, also with bullous skin lesions. Bullous skin lesions. Why? I'll tell you when you're older. You're not old enough yet. I'm not going to tell you. I'll tell you when you're older and mature and professional, like me. The other answer is, I don't know. He just likes to eat iron for lunch. Don't ask me why. That's just the way it is. There's an organism that likes to eat iron for lunch. Maybe you like sushi. This likes to eat iron. So that's all the infectious diarrheas. So first thing, before you go to other forms of diarrhea, always exclude the infection. Always exclude the infection. And that means stool for white blood cells. Stool for red blood cells. Stool for ovum parasite exams. Stool for Giardia and Cryptosporidium. Stool for antigen. If all of those stool things don't help, if you have been stoolish and you don't know what to do, endoscopy. Stool, stool, stool. If you don't get the answer then endoscopy. Stool, 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 scope. Endoscopy, colonoscopy. If you've done the stool and the stool and the stool and you don't know what to do, then endoscopy. Well, there's one other infectious diarrhea that's a little bit different because the diagnosis is a little more obvious. 68-year-old guy gets admitted for pneumonia. And after 3 days of pneumonia, 5 days, 3 to 5 days, he starts to develop diarrhea. And you go, I know what this is. This is diarrhea associated with antibiotics. And you are right. Stool for Clostridium difficile toxin is positive. Stool toxin is positive for Clostridium difficile. And the stool C. diff toxin is positive, and he gets metronidazole, and the metronidazole makes him all better. Now, first of all, what I'd like you to notice, the most common antibiotic-associated diarrhea is Clostridium difficile. The most common antibiotic-associated diarrhea is Clostridium difficile. Number 2, the test is a stool Clostridium difficile toxin. Now, some of you would call it difficile. Now, why is difficile, or as you would say it, difficile, diagnosed by toxin? Why not diagnose it with a culture? And the answer is Clostridium difficile is very difficult to culture. No es fácil, es difícil. And that's why it's named Clostridium the difficult. A while ago, 20 years ago, they used to think Staph aureus, 30 years ago. Staph aureus would cause diarrhea, yeast, because we kept culturing and culturing and culturing. And what comes out? Stool and yeast. So therefore, what it was proven is that it's not that it was yeast or Staph aureus, it's that the tests we were doing weren't growing the Clostridium difficile because it's an anaerobe. Therefore, the Clostridium that's very difficult, Clostridium that's difficult to culture, you test for with the toxin. Clostridium that's very difficult to culture, you test for with a toxin. And that's why it's a toxin test. Because the culture no es fácil, es difícil, difficult to culture. The metronidazole makes it better because this is an anaerobe and this is an anaerobic drug. And 10 days later, damn it, 10 days later, it recurs and it comes back. Damn it, it came back 10 days later. What are you going to do now when it comes back 10 days later? 10 days later, it comes back. What are you gonna do? The answer is retreat with metronidazole. Oh, I bet you thought about switching to vancomycin, didn't you? How does he know what we're thinking? Because sins are reproducible. They're very easy because everybody makes the same mistakes. Vancomycin is if it never got better. If you give metronidazole and instead of getting better, it persisted, then you go to vancomycin. Vancomycin is when the C. difficile does not get better. Now, that is less than 5%. 95% of the time, if the diarrhea persists, it means it wasn't C. difficile and you've got something different in your stool than the Clostridium difficile. 95% of the time it should get better. If it gets better and it recurs, retreat. Persists, switch. If it stays the same, switch. If it recurs, retreat. Persists or stays the same, switch the drug. Recurs, retreat with metronidazole. The first thing that you should look for in any acute diarrhea case is blood or no blood. Blood is more important than risk factors. Blood is more important than risk factors. The first thing you do is blood. The best initial test is white cells. The most accurate test for infectious diarrheas is a stool culture. However, as in most of infectious diseases, you never have the results of your culture at the time you need to make the treatment decision. You don't have the culture. The culture is 2 days from now. So the whole thing in infectious disease is empiric, probabilities. What's it going to grow? You don't have the results of the culture now. But you know whether there's pain and fever and blood and tender and pain and fever and blood and tender. 28-year-old video camera operator has lunch at 3 p.m. At 4 p.m., he is in the Kaplan Center and has explosive bloody diarrhea. He has a fever of 102 degrees all over the center manager. 28-year-old man has lunch at 3 o'clock. At 4 o'clock, he has explosive bloody diarrhea. What's the most likely cause? Well, Bacillus cereus is not the most likely, and neither is Staph aureus. Campylobacter or Salmonella is the most likely cause, because you don't get bloody diarrhea from Bacillus cereus or Staph aureus or viruses. So although he may have had lunch at 3, you don't get bloody diarrhea in 1 hour. I don't care how much Staph aureus you had at lunch, you can't have bloody diarrhea an hour later. 28-year-old guy has Chinese food at 3 o'clock. At 4 o'clock, after his lunch of Chinese rice, he has explosive bloody diarrhea and a temperature of 102 degrees. What's the most likely etiology? Not Bacillus cereus. Although Bacillus cereus is associated with Chinese food, and although it's associated with the toxin on refried rice, no amount of Bacillus cereus can give you bloody diarrhea. So it's not so much the food you ate. The most important thing is whether or not there's blood and fever. The other thing is the timing of when he ate it is not as important as whether he has blood or white cells. The most important thing in the diarrhea case is not what you ate, it's whether you have blood, white cells, fever in your presentation. Yes, it's true that Chinese food is associated with Bacillus cereus, that Salmonella is with chickens. Yes, that's true. But more important than what you ate is what's your individual presentation. There are 2 parts of a question. One is the risk factors, the other is the individual presentation. And the individual presentation is more important, always more important than the risk factors. This is always more important than the risk factors. Now, I didn't say risk factors were unimportant. I just say that they're less important than the presentation. We will do chronic diarrheas in the next tape. This is infectious diarrhea. Remember that the first thing is always to exclude infection. You can't go on to inflammatory bowel disease, lactose intolerance, carcinoid syndrome, or malabsorption until you've excluded the infection first, simply because food poisoning is far, far more common than those other forms of diseases. Chronic diarrhea, here we come. After you've excluded the infectious diarrhea, after you've excluded the acute, chronic diarrhea. Does that sound exciting? Is that the most exciting you've ever found diarrhea in your entire life? Poo-poo everywhere. Now, what is the most common cause of chronic diarrhea? Well, by far, infinitely more than all the others, is lactose intolerance. Depending upon the group, minimum 25% of the adult population is lactose intolerant. 25% to 75%. Lactose intolerance is easy to distinguish from the others because of the complete absence of fever. The complete absence of blood. Ever. Never blood. Never fever. Rarely, if ever, weight loss, because you can absorb the other sugars and the other fats in higher amount. Never fever, never blood, never anything that looks like an infection. Now, although as a diagnostic test, we can give you a glass of milk, got milk? However, the more common thing is just to remove milk and milk products from the diet and see if someone gets better. In other words, milk, cheese, ice cream, everything except yogurt. Remove it from the diet. This is far more effective than doing things like checking stool osmolar gradients. There is an increased stool osmolality. However, this is almost never done, checking stool osmolality, because it's not necessary. Remove the milk from the diet, they get better, and you are done. Now, what is the major difference between irritable bowel and all the others? What is the difference between irritable bowel syndrome and all the other forms of chronic diarrhea? It's not going to be what you think. For instance, although irritable bowel syndrome does present with diarrhea alternating with constipation, the biggest issue about irritable bowel is not the diarrhea alternating with constipation. That's true, it does alternate with constipation. And there's no infection that alternates with constipation. It's not like you can have viral diarrhea on Monday, Wednesday, and Friday, and on Tuesday and Thursday you are constipated. It's not like you can have constipation from lactose intolerance. So alternating with constipation is true. But what unique thing is different compared to all the other syndromes, compared to carcinoid, compared to inflammatory bowel? Irritable bowel is predominantly a syndrome of pain. Irritable bowel is a pain syndrome. The major issue is abdominal pain. Now, why this is the main issue is that 20% of patients have no diarrhea at all. 20% of patients are presenting just with constipation. Irritable bowel syndrome is a pain syndrome that often has diarrhea, not a diarrhea syndrome with pain. It is a pain syndrome. In other words, I have pain. That pain sometimes gets better with a bowel movement. Or it gets better by switching from constipation to diarrhea or from normal to diarrhea. But irritable bowel is predominantly a pain syndrome. That is the major issue with irritable bowel. It is a pain syndrome with diarrhea, and diarrhea alternating with constipation. That is the major issue. It is diarrhea alternating with constipation, and also the symptoms are not at night. And that's the other difference. It's symptoms that are not at night. Okay? It's symptoms that are not at night, and that is the other big difference. Because when you're not awake, you're not going to have the diarrhea. You see, when you have inflammatory bowel disease, your Crohn's disease does not go away when you're asleep. When you have inflammatory bowel disease, your ulcerative colitis is not going to go away just because you're asleep. You're having it, and it wakes you up. To get woken out of bed to have diarrhea, that is a big deal. It means that you have an uncontrollable diarrheal disorder. That's not irritable bowel. Irritable bowel is like non-ulcer dyspepsia. Why do you get it? I don't know. You could say that you were told it was nerves. You could say that it's associated with anxiety. You could say it's associated with depression. You could say it's associated with demonic possession. I don't know. It happens. People are in pain, and it gets better when you change the bowel habit. It's better when you have a bowel movement. But remember, 20% have no diarrhea at all. They just have constipation. And when you have diarrhea predominant, you take a lositron, a 5-hydroxytryptamine agonist. And when you have constipation predominant, you're going to take tegaserod. Tegaserod and a lositron are 5-hydroxytryptamine alternating drugs. SSRIs, serotonin reuptake inhibitors, the Prozacs, Zolofts, Paxils of the world. That neurotransmitter of serotonin was first described in the bowel. It was later described in the brain. But serotonin, which we so avidly play with to manipulate people's depression, with Prozac, Zoloft, Paxil, all the others, Celexa, was originally described in the intestines. What are GI hormones doing in my brain? It proves the way to make people have something to be happy, have something to eat. You'll feel better. It proves it. There's GI hormones in the brain. The 5-hydroxytryptamine alternating drugs, allosetron and tegaserod. Diarrhea predominant inhibits 5-hydroxytryptamine. Constipation predominant, diarrhea predominant, allosetron. Constipation predominant. What causes irritable bowel? We just don't know. We do know that everybody should get treated with fiber and bulking agents. And bulking agents and fiber help you because if the bowels are getting into a spastic twist, and you give this fiber and bulk, the bowels can get as spastic as they want. Because now there's so much bulk there that when your bowels get in a spastic twist, instead of going now they have all this fiber. Ooh. And it's like the bowels are bouncing on a big trampoline inside your bowels instead of just constricting. There's anti-spasmodics, hyoscyamine, and belladonna alkaloids, hyoscyamine and dicyclomine. These are antispasmodics. Hyoscyamine and dicyclomine are antispasmodic medications that when your bowels are having their spasm causing pain, the bowel is a big muscular tube covered by epithelial cells. The bowel is a long muscular tube covered by epithelial cells. And when those muscles of the bowel overconstrict, become clamped down, hyoscyamine, dicyclomine to help as an antispasmodic of the bowel. Fiber to make it so that it doesn't have as much spasm. All tricyclic antidepressants. Tricyclic antidepressants work for 3 reasons. One, they're anticholinergic. Acetylcholine constricts the bowel. Anticholinergic means that they're going to relax the bowel. So acetylcholine constricts the bowel. Anticholinergic will relax the bowel. Point number 2, tricyclic antidepressants. 40% of patients with irritable bowel have a very significant depression history. If they're antidepressants, it helps the people's depression who are associated with irritable bowel. Third thing, tricyclic antidepressants are really analgesic medications for neuropathic pain. In other words, when you have a peripheral neuropathy, tricyclic antidepressants like amitriptyline, nortriptyline can be used for pain. They're analgesics, they're antidepressants, and they're antispasmodic because they're anticholinergic and relax the bowel wall. The other answer is they work and we don't know why, since we don't know what causes the disease. Carcinoid syndrome is mostly in your endocrinology section, but carcinoid syndrome is unique. Carcinoid syndrome is unique. Okay? Carcinoid syndrome is unique because carcinoid syndrome ends up causing you to have the only one that is not only intermittent, but the others are not going to give you flushing, wheezing, diarrhea, flushing, wheezing, cardiac problems, flushing, wheezing, tricuspid insufficiency, and pulmonic stenosis. Flushing, wheezing, and cardiac problems. Why? Because carcinoid syndrome is bathing the right side of your heart in those neurotransmitters, and they're causing chronic fibrosis of the right side of your heart. They're causing chronic fibrosis of the right side of your heart with that carcinoid syndrome. Intermittent flushing, wheezing, tricuspid insufficiency, pulmonic stenosis, tricuspid insufficiency, and pulmonic stenosis. And that's what's different about carcinoid from the other things. Tricuspid insufficiency and pulmonic stenosis. Okay. Intermittent flushing. Now, it has its own unique test. A 5-hydroxyindole acetic acid in the urine. 5-hydroxyindole acetic acid urine level is unique to carcinoid syndrome. It has a unique therapy, which is octreotide, the somatostatin analog. Octreotide stops the diarrhea of the carcinoid syndrome. It has a unique test, 5-hydroxyindole acetic acid level in the urine. It has the treatment that is a somatostatin analog, octreotide.